Hello everyone, welcome back to my channel. Today we're discussing a gastroenterology topic. We're discussing about IBS, which is irritable bowel syndrome, and IBD, which is inflammatory bowel disease. These two are very common topics we come across, and they can be quite confusing at times. So let's go back to basics, understand them, and ace them. First, let's talk about the basics of irritable bowel syndrome, which is IBS. In IBS, this is a chronic recurrent illness, that is, once a person is diagnosed with IBS, they would have to live with it. What actually happens in this? The pathophysiology is less known, but it is known that there is issues with the enteric system, the gut-brain axis. Here, if you go back to the anatomy, the enteric system consists of Meissner's plexus and Meindrick plexus. Meissner's plexus are present in the submucosal layers and Meindrick plexus are present within the intestinal smooth muscles. The problem here comes with the Meindrick plexus, where Meindrick plexus, as we said, they control the motility of the gut. And the problem with the Meindrick plexus leads to dysmotility of the gut. So, your symptoms are constipation, diarrhea, bloating. These are common presentations of IBS. So why does this pathology with the Meindrick plexus develop? There could be various reasons why this starts. One could be food triggers. So certain people have triggers to certain food which disrupts the Meindrick plexus. Second, it could be post-infective. So if a person has diarrhea secondary to say E. coli or any other bacteria or virus, the gut becomes very sensitive and the Meindrick plexus is impaired and they have motility issues after this episode of diarrhea or this episode of infection. The other could be due to say changes in the mood. If they are very anxious, they're depressed. So any change with the brain and stress levels can lead to changes in their motility of the gut because of the impaired Meindrick plexus. As we discussed, the pathophysiology is quite vague. But the take-home message is that it's not an infection, it is not an inflammation, it is a functional pathology. It is a motility issue which is secondary to different causes. How do we diagnose the IBS? We have something called Rome criteria. Now the present one is Rome 4 criteria. So the Rome criteria depends on the stool frequency, that is number of stool a person passes, and if their symptoms, that is bloating and abdominal pain, is consistent to a defecation episode. And if there is change in the bowel frequency and if there is change in the consistency of the stool as such. So IBS is a clinical diagnosis. It does not have a confirmatory lab test or confirmatory endoscopy testing. Criteria helps with the diagnosis because it has a timeline and it has the symptoms of the patient presents. That IBS is not a diagnosis of exclusion. So you cannot say that because the patient does not have these bowel problems, it could be IBS. IBS is a definitive diagnosis and it has to be based on the Rome criteria. Certain blood tests that you could do to rule out other important pathologies such as IBD, which we will discuss later on. The test we are talking about is fecal calprotectin. Fecal calprotectin is secreted by neutrophils in terms of inflammation. So if there's an inflammation, neutrophils come into picture and they release the calprotectin. And this calprotectin is found in the feces. So if you have fecal calprotectin, that means there is some sort of inflammation in your bowels. And it is not IBS because IBS does not have inflammation. It could be IBD, it could be malignancy, or it could be any other infection in your bowel. So we understand IBS affects the bowel. But what part of bowel does it affect? It can affect the whole GI tract. Could affect the stomach, which may cause delayed emptying or early satiety. It can affect the small intestines, it can affect the large intestine, it can affect any part of the bowel. Yes. Treatment of IBS is symptom controls. There is no definitive treatment. It is just symptom management. Depending on symptoms, you could give them laxatives if they're constipated. And here the choice of laxatives would be macrogols, which is an osmotic laxative. Second, if they have a lot of diarrhea, they have a lot of loose stools, then you give them some loperamide. Spasms, abdominal cramps, then you would give them antispasmodics such as nebivolin. Lifestyle management such as stress management, because stress can trigger the gut-brain axis. Also, dietary changes can play a major role. If the lifestyle changes and stress management do not help, antidepressants such as tricyclic antidepressants and SSRIs, which are selective serotonin reuptake inhibitors. Biochemical tests such as iron tests, B12, folate, liver function tests, but these do not have any diagnostic impact. There could be nutritional deficiencies because of the malabsorption. In general, people also end up having a colonoscopy or sigmoidoscopy because of chronic diarrhea to rule out IBD and malignancy. Stool microscopy could be done to rule out infective pathology as well.